esophageal diseases. My name is Rehan Haidry. This is now my fourth time in Yaroslavl, so before I start I just want to thank the organising committee, Sergey, Natalia, the entire team for inviting me back. I'd like to congratulate you on a fantastic course. Every year I come, the course has got bigger and better. And the reason is because of the experts, but also because of the fantastic input from the delegates. We have a really busy schedule this morning with some fantastic lectures from experts in the field, but in order for us to make it a fun, interactive session, we need you to ask us questions, really challenge what we are saying, and make it interactive and informal. Every year that I've been here, the esophageal symposium has got bigger and bigger, so now we've had to come downstairs, so we have a bigger room. And you know, who would have thought that a tube that is 25 centimeters long can cause so many problems and interest so many people? But it is a tube that is instrumental in how people eat and drink, and from inflammatory conditions, motility problems, neuroplastic processes, the importance of the esophagus cannot be undermined, and that will be outlined this morning. We will start this morning's session looking at a little bit on key performance indicators and quality measures in upper endoscopy for standard upper endoscopy. Professor Hafner will then talk a little bit about the quality metrics around the diagnosis of esophageal cancer, adenocancer, but also squamous cell cancer. We will then hear a little bit about the use of minimally invasive endoscopic treatments with endoscopic ablation, in particular radiofrequency ablation, which you saw yesterday. We'll then take a coffee break, and then we'll move away from neoplasia to some of the benign conditions of the esophagus, looking at motility, looking at achalasia, and then finishing off with eosinophilic esophagitis. So I encourage you all to keep this as interactive as possible, and to ask questions as we go along. And I'd like to thank my co-chairs for their time this morning to support this session. So without further ado, I shall make a start and really set the scene for a lot of what we saw yesterday. Upper endoscopy has come a long way in the past decade, driven through industry, through technique, but we still have a huge variation in standards around the globe. Certainly in my country, we are pushing really hard in the UK to try and homogenize the practice, because we know that the outcomes from esophageal cancer, from gastric cancer remain really poor. And as we saw yesterday, in all of the minimally invasive endoscopic techniques that we have for curing these diseases, that if we can detect them early through high quality upper endoscopy, then we can offer these patients every chance. And so I'm going to go over in my lecture this morning, over the next half an hour or so, some of the quality measures in upper endoscopy, which we can all adhere to in our practice, which we can show our fellows based on just the recent ESGE, but also the British guidelines. These are my disclosures. So the problem that is quantity is something you count, the quality is something that you and your patients will count on. And how do you find this equilibrium between the two? So things have come a long way since the days of fiber optic endoscopy. This is Professor Hafner carrying out his first endoscopy back in the 60s. And as you saw yesterday, the optics that we have available now are fantastic. But what are the challenges? The challenges are that nationally, through government-driven initiative, there was a big drive for early diagnosis, a big drive on ensuring that there are population-based awareness campaigns about the signs and symptoms of early cancer, acid reflux, heartburn, dysphagia. And this drives an increased demand for upper endoscopy. And what that means is that we have to train more and more endoscopists. In the UK, we now have a big drive to train what we call non-medical endoscopists, nurse endoscopists. And as a result, there's a big variation in practice. Not everyone can be like an expert where they know exactly what to look for, when to look for it, and what to do. And so these are the challenges that are facing us in terms of the quality of endoscopy. So why is quality important? It's important because we, as clinicians, as endoscopists, we need to provide the best possible procedure for our patients. Every endoscopy that we do should be the best that patient can have, so they have every chance to exhibit their disease. And we know that evidence exists that performance measures result in better outcomes. We know this from colonoscopy data. And we've seen that as we have driven standards up in colonoscopy, the basic thing, and most importantly, it's better for the patients. The patients are happier and they're more comfortable. But also, within the confines of health care and the strains that we have, this means that you don't need to repeat the procedure. So actually there is a cost benefit here because there are also fewer additional treatments from adjunct therapy from when patients progress to cancer. So there is a cost effectiveness argument for maintaining quality. So is there a problem? Do we need to improve? So let's focus on the upper GI tract because we're here to talk about the esophagus. So this is a meta-analysis from some of my colleagues in the United Kingdom which looked at the miss rate. We talk a lot about adenoma and miss rates in colorectal cancer. And this was a meta-analysis looking at 13 studies of patients with upper GI endoscopy. And they found that up to 11% of upper GI cancers were not diagnosed with preceding endoscopy 3 years ago. And as many as 6% within the first year. So although not conclusive, suggesting that maybe 1 in every 400 upper endoscopies that have been carried out in this cohort of studies, we were overseeing early cancer. So there is a need to improve. What about detection of Barrett's neoplasia? This is something that we see more and more of now. This is a study which was published in the New England Journal of Medicine from, I think, Denmark, which looked at over 10,000 patients with Barrett's and a median follow-up of over 5 years. And they found that up to 66 patients who had adenocarcinomas detected after the first year were detected in the first year of follow-up. So these were not new cancers, these were prevalent cancers, which were there but were missed without index endoscopy. So, as we will see in my lecture today, but also in some of the other talks, high quality endoscopy in Barrett's esophagus will help to detect early neoplasia, and then the ablation and the resection will follow later. Sticking to the detection of Barrett's esophagus, this was published 2 years ago by colleagues in Holland, which looked at nearly 200 patients who were referred to a specialist center with high-grade dysplasia or intramucosal adenocarcinoma. And if we just look at the patients to the right of your screen, the patients who were referred without a visible lesion, so these are patients who have had a diagnosis of cancer, and when they had a diagnosis, when they had an endoscopy at an expert center, actually the majority of these patients did have a visible lesion, and up to 76% of them did have visible neoplasia. So there is a variation in practice between community hospitals and specialist centers in detecting early neoplasia in Barrett's. So what is the solution? Do we just make sure that we hire ourselves some very good lawyers for the lawsuits that will follow when we miss all these cancers, or do we improve? And this is why we have quality standards. So this was published 2 years ago in GUT, this quality standards in upper endoscopy. This was a joint position statement between the British Society of Gastroenterology, but also the Association of Upper Gastrointestinal Surgeons. And over the next few slides, I'm going to go over some of these in a bit of detail to actually look at the granular detail of what should we be doing in our upper endoscopy. And you will see from some of these listed metrics that it's very, very basic things, from how we take photos in our endoscopy report, how we wash the upper GI tract, how we define a lesion, how we take biopsies, to how we follow these patients up in terms of follow-up procedures for early ulcers, the management of celiac disease, the management of H. pylori. For the focus of this lecture, we're going to stick on the esophagus. These are the ESGE, upper GI endoscopy performance measures, which were published a year before in endoscopy, led by Professor Bishops and Matt Rutter from the UK. And again, ladies and gentlemen, you can see how basic these metrics are, from looking at how patients fast before they have their upper endoscopy to ensure they have a clean upper GI tract, ensuring that the procedure time is adequate to give you every chance to detect dysplasia, to identification of pathology and nomenclature within the upper endoscopy reports, and then also the management, the quantity of procedures that are carried out per annum, and as important at the end is what we do with these patients afterwards. So before we even come to talking about the procedure and how we do the procedure, is actually the basics are done very, very poorly. When I travel around the UK, one of the things that we see actually is that the quality of the reporting tools is so variable. So some hospitals will have Endobase from Olympus or Unisoft or some of the other generic states, where there's still some units where they're handwriting an endoscopy report. And so it's mandatory that an electronic, homogenized, standardized reporting tool is integrated into the hospital's IT system. And this helps to integrate patient identifiers, to link all data together. And one of the things that we need to move away from in endoscopy reporting is free text, and have structured, standardized data entry for audit, but also for standard reporting. This also enhances the quality of audit, but also research, and avoids double entry, and has to include not just endoscopic findings and demographic data, but also pathology, and helps, as I said, to audit the key performance indicators for operators, so we can hold accountable those who are performing beyond these quality metrics and aspirational standards, so we can help them to improve. If I am not told that my adenoma detection rate is poor, then I will just carry on doing colonoscopy the same way over and over again until someone says, stop, Rehan, you need to have a look at your colonoscopy practice, you need to improve your bowel prep, you need to improve your procedure time, and only then will I take the time to come to a congress like this, learn from the experts, and improve my practice. So we talked about reporting, and I said I'm going to keep this very, very basic before we get into some of the more advanced stuff. This is the sort of thing that we need to avoid in reporting our endoscopy report. So this is free text, and this is from one of my fellows in my hospital, who has written, I see a long segment of Barrett's, 6 centimeters, small height of hernia. There is nodularity in the distal part of the Barrett's. That is biopsy. Who thinks that is sufficient as an endoscopy report? Hands up. Good. So actually what this should be is an electronic report which will see a Barrett segment. You will enter the metric that the diaphragm is 42 centimeters and the top of the gastric fold is 39 centimeters, which tells you that there is a 3 centimeter height of hernia. You will then automatically calculate the Proud classification by clicking on where the top of the circumferential extents of the Barrett's are, where the top of the tongues are, giving you a measurement of C3 and 6, with 36 and 33 centimeters respectively. You will then identify that there is a type 2A lesion in the 9 o'clock position, and you will take a biopsy, and this will be termed with 36 centimeters, either 9 o'clock or on the left wall. And this is a standardized endoscopy report. So the next person who does the endoscopy knows exactly where to look. Your pathologist will know where you took the biopsy from, and the patient can read this, and the GP can read it, the referring clinician can read it, and understand exactly what we've done. So what is the minimum number of procedures that we need to be carried out to perform a high-quality examination? So this was not addressed in the ESGE document, it was done in the DSG document. And this is very, very difficult to police. And the reason for this is to brand what I call the occasional endoscopist. So the surgeon in the UK who will do one gastroscopy every 3 or 4 weeks. That is not right. They shouldn't be doing it. The patient would rather not be having that procedure. And this is to maintain quality, to ensure that there is a high quality of lesion recognition, and maintain training to improve detection of early carcinoma. And so this was based on some very weak evidence, but the BSG position statement said that we need to be carrying out a minimum of 100 upper endoscopies per annum to ensure that we maintain a high quality procedural practice. This is an aspirational standard, and as I mentioned, this is not based on hard evidence. Let's now look at fasting prior to upper endoscopy. So this is from the ESGE position document, which looks at patients who received proper instructions for fasting. So complete fasting for 2 hours before the procedure for liquids and solids, and 6 hours for liquids. And the only exclusion here was emergency out-of-hours endoscopy. And where's the data for this? If we look at these 2 studies, which looked at patients who had a 1 hour fast for water and then a 6 hour fast for solids prior to upper endoscopy. This is the first study, it was a randomized study where patients were randomized to either a 6 hour fast or drinking water up to 1 hour before. And you can see actually that the visibility significantly improved in the cohort of patients where they've had a prolonged fast. And actually the risk of aspiration or adverse events is really very, very low. So the take-home message is that the instructions to your patients have to be very, very clear. They need to fast adequately from solids and liquids before the procedure, so that they give you every chance to be able to see the mucosa and not have to rebook and repeat their procedure. We looked yesterday at some of the different cleansing agents that we use, and we have spent so many years looking at different bowel preparations for colonoscopy, split bowel prep, and the quality of bowel prep ensures whether we have good adenoma detection rates. And so the same is relevant to the upper GI tract, where pre-medication with either something like simethicone to remove the bubbles, or a mucolytic agent such as N-acetylcysteine will help to improve visibility during upper endoscopy. This was a randomized trial which looked at, we actually need to do something more than just fast the patient. We need to clean the mucosal layer, and patients are randomized to either drinking just pure water 15 to 30 minutes before the procedure. A second group of patients drank just water but with some simethicone inside it. And then a third group of patients drank water with simethicone and a mucolytic, which was N-acetylcysteine. And if you look at the visibility of the mucosa, and this is based on clinician feedback in the patients who just had water compared to the other 3 groups, it was statistically significant, especially in the esophagus and the stomach, that the combination of the mucolytic but also simethicone improved visibility of the esophagus and the stomach. So this is something we do routinely in our unit. All patients at the time of consent will get, we give them 50 ml of simethicone and acetylcysteine, I don't know if the other experts do that in their unit. This makes a big difference. A simple intervention to give you every chance to enhance the quality of your endoscopy. The second thing is photo documentation, the key anatomical landmarks. And I think that if you haven't taken a photo, which means that you haven't looked at it. And say in colonoscopy, we are encouraged to take photos of the terminal ileum, the ileocecal valve, the cecum, etc., etc. The same needs to apply to photo documentation of the upper GI tract. I'm amazed when I go to China and Japan, the number of photos that they put in their endoscopy reports is fantastic. And the reason is that if you're taking a photo, then you're looking at that area. And so this again was from the ESGE position statement saying photo documentation of all anatomical landmarks is an indicator of a complete procedure. So this needs to include not just all the normal landmarks, but also accurate photo documentation of your abnormal findings. And this allows for accurate communication in terms of MDT follow-up, etc. And the metric was that at least 10 pictures of normal anatomical landmarks, the duodenum, papilla, the antrum, the incisura, the corpus, a retroflex picture of the cardia and fundus, the diaphragmatic indentation, the squamocolumnar junction, and then the distal, mid, and upper endoscopy, as well as pictures of all abnormal findings. So this is, take pride in your endoscopy pictures. Don't just take a blurry picture. Wash, use your freeze function. And these are the ESGE recommendations. This is actually historic data, which is, and you can see all the different places from where we need to take pictures. And so it's not good enough just to have one picture of the esophagus and one of the duodenum to show that we got there. We need to take pictures of all these places on the way back, so we can actually show that we've looked at it. This is, in my opinion, the bare minimum that you should have in your endoscopy report, which is a picture of the proximal esophagus, the distal esophagus. You then need to take a picture of the squamocolumnar junction, the diaphragm, the height of hernia, a retroflex picture to look at the cardia and fundus, and then as you go through the lesser curve, the greater curve, the incisura, antrum, a picture of the duodenal bulb, the ampulla, and then also any visible lesion. So this is a core minimum standard. So these are the AGA and ASGE quality indicators for Barrett's esophagus, and this involves exactly the same thing in this complete agreement here that photo documentation of the landmarks is paramount. And if you look at practice, not just in Europe, but also in the United States, the adherence to these statements is poor. And we found that in centres or clinicians who adhere to accurate photo documentation of key landmarks had higher detection rates of dysplasia. So again, if you're taking these photos, it means you're looking, and therefore you're more likely to pick up neoplasia. We then come to the reporting the duration of the procedure, and again, if we take the analogy of colonoscopy, we have done so many studies looking at colonoscopy withdrawal time and how this corresponds to our detection rates of early adenomas. I have seen clinicians in my hospital get to the duodenum and pull the scope out while they're not even looking at the patient in under 2 minutes. It means they are not looking, and therefore the duration of the procedure relates to the quality of their inspection, and this will manifest in a higher diagnostic yield during your upper endoscopy. So let's stick to Barrett's esophagus, and I know that we will talk a little bit about Barrett's esophagus earlier on, and this is data that was published from our colleagues in Kansas, something called a Barrett's inspection time bit, and we know that you need to be spending about 60 seconds per centimetre of Barrett's mucosa in order to pick up dysplasia. And so this was a study which showed that in patients in clinicians who spent less than 1 minute per centimetre compared to those that spent more than 1 minute per centimetre, found more suspicious lesions, but also detected more dysplasia. Now, this was an enriched population, but still the analogy holds. This is common sense. You don't need to do a study. The longer you look, the more likely you are to find it. So this is embarrassed esophagus. What about the total procedure time for the upper GI tract? I know this is an esophageal section, but essentially 7 minutes is now a global consensus that you need to be spending at least 7 minutes for the first upper endoscopy, but also in the follow-up of patients with gastrointestinal metaplasia, and that is from intubation to extubation, to give ourselves every chance of detecting not just esophageal neoplasia, but also to look for GIM. What's the data on this? This is data from Singapore that was published about 3-4 years ago, which looked at clinicians who had a slow versus a fast procedure time. And again, it goes without saying that the detection of high-risk lesions, but also the detection of neoplasia, was lower in the clinicians who had a very fast endoscopic time compared to those who took their time to look for more neoplasia. So again, this is like colonoscopy. This is data that was published a couple of years ago. Longer observation time increases the number of cancers that we detect at upper endoscopy. This is a Korean study which looked at a huge proportion of patients, over 100,000 patients, average withdrawal time of 3 minutes. And again, they looked at clinicians who carried out a slow versus a fast upper endoscopy. And again, ladies and gentlemen, you can see that the detection of early gastric cancer, esophageal neoplasia, and all neoplasia was significantly higher in the clinicians who carried out a slow, meticulous examination compared to those who just put the scope in and pushed it out again. So again, you don't need data to tell you this. This is common sense. We then move away from some of the procedure-based metrics in terms of technical skills, but also the application of standardized terminologies for reporting abnormalities that you see, and we're going to stick just to the esophagus here. And this looks at really 3 or 4 things. One is the LA classification for erosive esophagitis. This is something we don't see very often, but the Zaga classification called caustic esophagitis. When I ask my fellows and even my clinicians in my unit what this is, they look at me blankly because they've never heard of it. And then obviously the PRA classification, which we saw in the live demonstrations yesterday, which is standard practice for most of you. And then also the Forest classification, which is a standardized classification for reporting of peptic ulcers. I won't talk a little too much about Spiegelman and Paris classification in this lecture. So the PRA classification, as we described yesterday, is a standardized way of reporting Barrett's esophagus. And this looks at the circumferential length of the Barrett from the maximum extent of Barrett's, as defined as the oral end of the columnar mucosa. And this was agreed on many years ago by experts. And you can see that the kappa values in terms of agreement is very, very good. So this really has now globally become accepted as the bare minimum standard for reporting Barrett's esophagus and should be part of every upper endoscopy report. What about reflux esophagitis? Again, this is in the context of acid reflux and patients with PORS, something that we see a lot of. And the LA, the Los Angeles classification, again has become standard practice. So from Group A, where there is just a single mucosal break, which does not extend more than 5 millimeters, to Grade D, which is confluent circumferential ulceration. But again, when we looked at the kappa agreements in terms of what experts agree, there is variation, but at least it's been looked at and gives you a reference for a follow-up endoscopy to to see whether this has improved or gotten worse. This is a Zaga scale for caustic injury. These patients should either be scoped immediately or they should not be scoped at all because of the risk of iatrogenic injury to the esophageal wall. There are essentially 5 grades from grade 1 to 3B, which looks at this sort of appearance where you have this hyperemia and tissue edema, to 3B, which is where really that endoscopy should not be done because they have devulceration, they have extensive tissue death and necrosis, and the significance here is these patients are going to do very badly. They're going to cause stenosis, they're likely to fistulate, and their prognosis is actually very, very poor with survival rate of less than 30%. Again, we're sticking to the esophagus, and we know that there is there are different grades for defining varices, but again, each unit, each endoscopy reporting tool will have one, and we have the Northern Italian Endoscopy Club, which looks at 3 different sizes, which are these small and linear varices, to then these bigger varices that take up to 30% of the circumference, and then these very, very large, almost like golf balls, that take up the entire esophageal lumen. So again, pick one and stick to this in your endoscopy reporting tool. I'm not going to spend too much time on the Forest classification because this is now for peptic ulcer disease in the stomach. But again, this should be standard practice for most of us doing upper endoscopy. And the reason for this is because it defines the risk of rebleeding, but also prognosticates the need for reintervention in patients. The Paris classification doesn't just apply to the esophagus, it applies to the stomach, to the colon, to the duodenum, and this really should be standard practice and part of the armamentarium of anyone carrying out upper endoscopy. And the reason being is that we know that as soon as you have these depressed 2C lesions, that the risk of submucosal invasion goes up. But again, ladies and gentlemen, you can see that even with experts, non-experts, the agreement of what one person calls a 2A and the other person calls a 2B is really very poor. But at least you're looking at this and it needs to be in the report for any visible lesions. We talked a lot about Barrett's esophagus, and I'm sure this will be covered in the next talk, which is the use of chromoscopy in patients with a high risk of squamous cell carcinoma. And this was discussed as a key performance measure and indicator in the ESGE guidelines, which was to stipulate that certainly in patients at high risk, so patients who previously had oropharyngeal or respiratory squamous cell carcinoma, they're at a higher risk of primary esophageal cancer, so they should have Lugol's chromoscopy to detect these Lugol's voided regions. Lugol's is widely available. It helps to stain neoplastic areas of squamous mucosa. The reason being is that Lugol's iodine binds to glycogen, which is abundant in normal squamous mucosa. And what happens is that when you have the neoplasia, you get a depletion in intracellular glycogen, and so you don't get this binding. So this is a patient who was referred to me with candidiasis, and you can see actually just with the white light image, this is not candidiasis. This is a patient with quite extensive squamous neoplasia. Sometimes this can be very, very subtle. An alarm bell should start ringing when you have isolated patches of candida or food in the mid-esophagus. And you can see just by spraying 1 or 2% Lugol's iodine, you can see these very nicely demarcated Lugol's voiding areas. This is indicative of squamous cell carcinoma and early squamous neoplasia. You can really see how extensive this lesion is. Whereas when you looked at the first picture, it's really very, very innocuous. So simple things that will help to enhance your detection rates. again, I'm sure this will be covered later, but adherence to the Seattle protocol, despite the huge advances in endoscopic imaging, we're still not in a situation where we can abandon random biopsies. Targeted biopsies, although very good, we still need accurate surveillance for optimal neoplastic detection of Barrett's neoplasia. And this was 4-quadrant biopsies, and this was published by Rehan et al. Back some nearly 20 years ago, which showed that in patients who underwent a 4-quadrant Seattle protocol biopsies every 1 or 2 centimeters compared to patients who didn't, had a much higher yield of neoplasia detection. So this has really become standard practice. So anyone carrying out upper endoscopy and Barrett surveillance, obviously you need to take targeted biopsies of any visible lesions or areas of interest, but your systematic 4-quadrant Seattle protocol biopsies still need to be carried out, and this is a key performance measure for those carrying out upper endoscopy. So, ladies and gentlemen, just to summarize, thank you very much for your attention. The context of this this talk was to set up the scene for what is to follow. But we've seen that the mortality from upper cancers is still very, very poor. Less than 20% of patients with esophageal cancer will be alive in 5 years. So if we can detect these cancers early, then we can develop or we can offer these patients endoscopic therapy. And there's a big variation in practice, and there still is a significantly missed neoplasia rate in upper endoscopy. And by streamlining our approach, not just of how we report upper endoscopy, but how we prepare these patients for the procedure, will improve early detection. And for those of you who would like to come and visit London in September, I'd like to invite you to. This is our masterclass looking at esophageal neoplasia. Thank you very much for your attention.
Уважаемые коллеги, есть ли у кого-то вопросы к профессору Рехану?
Можно вопрос?
Да,
Большое спасибо.
Там уже кто-то.
говорите, пожалуйста, микрофон, чтобы вас слышать.
Большое спасибо за очень интересный доклад и животрепещущие вопросы. Вот у нас в Хабаровске выступал профессор Нариса, студенту пытается выявить.
Thank you for your question. I think that's it's not something we do in the UK, but you're absolutely right. That when you go to the Far East or China, they take 30, 40 pictures, and then after the procedure they sit and they look through all the procedures, and if need be, they will then re-endoscope the patient. I think there's a balance between time for the procedure and following the procedure, and whether you can dedicate that amount of time to doing it. But certainly, I wouldn't fault you if you have access to flexibility within your unit to be able to do that for sure.
Пока это также мечта, как и для английских врачей. И еще вот хотел бы спросить, вот я знаю, слышал раньше, и вот вы сегодня тоже в докладе упомянули, что у вас выполняют медицинские сестры осмотры первичные при осмотре верхних отделов, нижних отделов желудочно-кишечного тракта. После них идет пересмотр или тоже только в том случае, если находят какое-то патологическое изменение? Понятно, что это связано с финансами, да, то есть использование среднего медицинского персонала. Но вот как вы сами оцениваете этот опыт и будет ли, на ваш взгляд, он распространяться по миру?
Yeah, so I think the introduction of non-medical endoscopists into the United Kingdom has revolutionized diagnostic upper endoscopy. So for colonoscopy, for example, we have bowel cancer screening program. We have now flexible sigmoidoscopy screening. In our unit, 75% of that is carried out by nurse endoscopists with abnormal detection rates that are over 40%. In my unit, I trained the 2 non-medical endoscopists that do all our Barrett surveys, and I am pretty confident that the quality of their upper endoscopy is better than most of my colleagues. And when we look at the reports, they are absolutely meticulous. And so I think non-medical endoscopists think in a very different way. They think in a very protocolized manner compared to us, where we try to get too clever and we try and think of slightly more abstract things. And the answer to your question is it has to be the future, because there's not enough doctors. You are all doing so many different things, endoscopy clinics, on calls, and so in my humble opinion is that the promotion of non-medical endoscopy is the future for high-quality diagnostic endoscopy.
Прошу прощения, один короткий вопрос. Мы в своей практике используем мобиловскую классификацию. Используете вы европейскую классификацию, как тем более сегодня электронные наши средства записи и видео, и изложение материала позволяет использовать? Используете вы или какую-то другую классификацию используете в своей практике? Мамедовская. Европейская, медовская.
Мамедовская, а не Мамедовская. Помню.
Какая классификация усредненных это есть для формальных отчетов? Классификация, может быть, признана в Европе, которую вы используете? Изложение материала. Нет. Стандартное использование протокола, стандарт протокола.
I'm not sure I know the answer though. I think each institution, each region will have a slightly bespoke reporting tool that will link and integrate to the local health system. So I'm not sure I know the answer to that question.
Well, OMED has developed the minimal standard terminology, and currently it's in version 3.0. So, and you can download it free. And I would say that many national societies use MST3 as a basis for the local national reporting guidelines, and that's something I'd recommend. If the Russian societies get together, use MST and maybe as a basis of some adjuncts to have a good national classification system.
So I think, ladies and gentlemen, I think what we will do is maybe take some more questions at the end, just because we need to catch up. So it's a great pleasure to introduce my friend and colleague, Professor Hafner. Michael has a wealth of experience